Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are now going to talk about calcium stones. Recall that this whole chapter is about what we call nephrolithiasis, otherwise called kidney stones. And kidney stones are the formation of what we call calculi that can deposit anywhere along the urogenital tract, such as in the kidney, in the ureters, and even down towards the bladder. And the creation of these substances causes an obstruction and ultimately pain for our patient. And this video is super important because calcium stones, specifically calcium oxalate stones, which I'm putting a red star by, are the most common type of kidney stone that you will see in a patient. So let's first talk about the pathophysiology here. And you can see that the creation of calcium stones is typically due to an increase in calcium or urinary oxalate, or phosphate. This makes sense to you, right? Because these are kind of the three components that we're going to talk about in this video that can create either a calcium oxalate stone or a less common calcium phosphate stone. The creation of these substances or the increase in these substances in the urine leads to something called supersaturation and ultimately stone formation. So that is to say, the problem in this disease is a supersaturation of substances in the urine that creates these stones, that creates these obstructions in the urinary system. Again, it's important to note here that the two main types include oxalate and phosphate. However, it is the calcium oxalate that is the more common of the two. The reason this is important is because sometimes in question stems, they will try to be a little bit tricky and they'll give you a presentation where it's obvious the patient has elevated levels of calcium and thus they're predisposed to a calcium type of stone, but it's less obvious what type of substance is then binding with the calcium. Is it phosphate or is it oxalate? And it's really based on that patient's presentation, which we'll talk more about in a second, that will help you determine what the ultimate answer is for the given question. It's also really important to know what are some of the things that can cause an increase in these substances in the body or the urinary system that leads a patient to have a higher risk of stone formation. So some of the common ones they want you to know include an increase in ethylene glycol or antifreeze. In a question stem, this is typically going to present as a patient who has ingested the ethylene glycol as a substitute for alcohol. So they often will give you a presentation of a patient who has an alcohol use disorder. They are unable to obtain the substances that they crave, and thus they find an alternative substance, potentially in the form of ethylene glycol, that they ingest instead. The classic findings for this condition are going to include things like a sweet smelling breath, altered mental status, and potentially our calcium oxalate stones. And so ultimately the overall principle here is that ingesting ethylene glycol increases the amount of oxalate that's in our body and ultimately our urine, thus increases the amount that is available to create kidney stones. The next one they want you to know that's very important is low amounts of citrate. And the reason for this is that citrate typically acts to bind calcium in the urinary system. This forms a soluble substance that can then be excreted in the urine. However, if we have low amounts of citrate, we have low amounts of a substance that will then bind to calcium. So what does that do to our free calcium? Well, we have more free calcium roaming around that can ultimately bind to other substances, maybe phosphate or oxalate, that can ultimately create kidney stones. And so that is to say that low citrate levels increase the amount of free calcium available to bind and form stones. Another really important one they like you to know is increased levels or excessively increased levels of vitamin C. And the reason for that is that vitamin C actually increases our overall oxalate levels in the body due to the metabolic process. And again, if we have more oxalate, which is a stone forming substance, this can then bind to excessive calcium, creating calcium oxalate stones. And the final one I want to talk about in this video that's particularly high yield is malabsorption. For example, Crohn's disease or potentially a patient who has had a gastric bypass. And the reason is that in these conditions, we get fat malabsorption. So patients with fat malabsorption, such as Crohn's disease, are then going to have increased amounts of fats or fatty acids in the GI system, right? They're unable to absorb these molecules because they have damage to the GI system, which typically would take them in. This becomes problematic because what this does is that these fatty acids, these bind to calcium. And typically in a healthy individual, our calcium is actually binding to our oxalate. Our calcium will bind to our oxalate in the GI system and be excreted in the kidneys. But if we have so much fat in the GI system that it binds to the calcium instead, we have an increased amount of free oxalate that then gets reabsorbed into the body. And now we have an excessive amount of oxalate in the body. And so patients with these malabsorption conditions, Crohn's disease is the most common one they will ask you about, are at higher risk of developing calcium oxalate stones for this reason. They will sometimes also ask you about the role of hyperparathyroidism in the formation of calcium phosphate stones. And the reason is that because in hyperparathyroidism, we have elevated levels of PTH. And what's the role of PTH in the body? That's right. It's to increase the amount of calcium reabsorption from our bone. And so if we increase the amount of calcium reabsorption, we have more of those stone-forming substances that we talked about that can create these stones in the urinary system. Next, I want to talk about the precipitation and some key differences. So for our calcium oxalate stones, we talked about how low citrate levels can cause an environment where there is excessive amounts of free calcium. This makes sense why this could form stones. Naturally, high levels of calcium, such as in hyperparathyroidism, can also cause an environment that is conducive to stone formation. And finally, high levels of oxalate can help form this environment as well, right? We have too much calcium, too much oxalate. It makes sense we're at risk for calcium oxalate stones. So this calcium oxalate environment, right, with high levels of stone forming substances or low levels of citrate is going to put a patient at higher risk of developing these. But the key one they want you to know for calcium phosphate is really more about the environment and that it's a high pH or an alkaline environment. This is in contrast to our calcium oxalate stones, which are more likely to develop in an acidic environment or one with a decreased pH. Next, let's talk about the diagnostics here. And for this particular type of stone, the calcium stones, we can look at them on X-ray or CT, and we would see them as a radiopaque substance, that is to say a bright or a white substance on imaging findings. This is important because we'll talk about in a future video a particular type of stone that you would not necessarily see as a radiopaque finding, and it's a helpful way to compare and contrast if given an answer, if given options in a vignette. Sometimes they might show you an image directly of a stone. Other times they will explain to you. They will say a patient comes in with unilateral colicky pain. They have all of these risk factors for developing stones. You get some imaging done and they'll describe to you what they find on the X-ray or the CT. And they might describe to you that there is a radiopaque circular substance in the left ureter, and they are describing to you what a kidney stone might look like in this patient's imaging. We also want to be mindful of the types of crystals we could see in these patients. So it's a little bit different for each one. So in a calcium oxalate stone, we will be looking at something that's kind of a dumbbell or envelope shaped, and in calcium phosphate stones, they describe it as more of a wedge shape. So rarely do I see them actually just give you an image and a question and say, which stone is this, right? Typically, it's a supplement to a really good vignette that should make it clear to you what type of stone the patient has. However, if you just think about the general structure that you might expect to see with a dumbbell, it might look something like this, and an envelope would look something similar to this. Again, I think it's more important to be familiar with the general shape or idea of the stone than to necessarily be able to pick out a picture of that particular stone. But always, always, always keep in mind that a vignette is not just going to give you this limited amount of information, right? They're going to talk about the patient's history. They're going to talk about the patient's symptoms. We want to use all of these clues in addition to potentially their imaging findings or their urinalysis findings to ultimately answer the question being asked. Next, we're going to move on to our management. And our management options here are very similar, and yet there are some subtle differences. So let's talk about them. For calcium oxalate stones, we can use thiazide diuretics. Now remember, think about our pharmacology here. Why might thiazide diuretics be helpful for decreasing or minimizing the formation of calcium stones in the urine? That's right, because one of the rules of thiazide diuretics is that it increases removal of calcium from the urinary tract. And so if we increase reabsorption of calcium, then there is less of it in the tubules of the kidney to actually precipitate and form calcium stones. The next thing that you might consider doing is alkalinizing the urine, and this can include using something such as potassium citrate. And this should make sense to you intuitively, right? Because we said that calcium oxalate stones typically tend to form in an acidic environment. This is in contrast to our calcium phosphate stones. So if they form in an acidic environment, you can attempt to create the opposite environment and thus decrease the chance of them forming. So if you alkalinize the urine by giving potassium citrate, you lower the risk of stone formation by disrupting the environment in which the stones would typically develop. Additionally, for both of these options, and I put a high yield button by it, you can consider a low sodium diet as a treatment modality. And the reason for this has to do with activation of the RAS system. So what happens when we have high levels of sodium in the body? That's right, we decrease the activation of our RAS system. So we said if we have high levels of sodium, we get a decreased activation in our RAS system. This is going to decrease our sodium and our calcium reabsorption. Because remember, sodium and calcium reabsorption in the body are indirectly linked in various parts of the nephrons, which we talked about in more detail in the nephron transporter series. But if having too much sodium decreases the RAS activation, decreasing our sodium reabsorption, and thus indirectly decreasing our calcium reabsorption, more calcium is left in the urine. So what you want to do is the opposite of that, right? If we now decrease our sodium, that would increase the activation of our RAS system, which is going to increase the activation of our sodium and calcium reabsorption, bringing more calcium out of the urine, and thus less of it is in an environment for it to create a kidney stone. So this is a particularly high yield finding, not only because they will give you the answer choice as an option for helping prevent or treat calcium stones in patients, but they also want you to understand this physiology, and it all ties into the activation of the RAS system. And notice that for our calcium phosphate stones, the treatments are really similar. Again, thiazide diuretics for the same reason, in that it pulls calcium out of the urinary system. And likewise, a low sodium diet also is indirectly a downstream effect going to pull calcium out of the urinary system. Finally, the last super important thing I want you to take from this video is that you should avoid calcium restriction. So it might make sense to you intuitively that if we're having the formation of calcium stones, well, let's just give them less calcium. We're decreasing the amount of substances that can create the stones. And intuitively, that makes a little bit of sense. However, physiologically, that reasoning kind of breaks down a little bit. If we decrease calcium intake, we then increase the amount of free oxalate, because a balance of calcium and oxalate in the gut, they will bind each other and be excreted in the feces. But if that balance gets thrown off for any reason, whether that's from too low of calcium and thus an increased amount of free oxalate, or as we talked about with Crohn's disease, in which the calcium then binds to the fatty acids, which also creates an environment of increased oxalate. So this is why this condition does not benefit from just simply decreasing calcium, because you just trade one problem for another. You decrease the amount of one forming substance, but then you increase the amount of another forming substance being taken up into the body with an increased amount of free oxalate, which can then go into the urinary system and bind to form stones. A classic presentation might include a patient who has a known history of hyperparathyroidism. They just finished running a marathon, and thus they're potentially dehydrated, low on volume status that can create an environment for supersaturation of stone-forming substances to occur. They're now presenting to the ED with colicky flank pain, potentially some hematuria, and in the ED they get some imaging done, whether that be an X-ray or a CT scan, which shows characteristic findings. Either they'll give you a picture showing a white stone on a CT or an X-ray, or they'll describe it to you as an obstruction in the ureters or the urinary system. And this constellation of findings of a low volume status, hyperparathyroidism, creates an environment that might put a patient at an increased risk for stone formation. Additionally, another classic vignette they will talk about is the one that we mentioned at the beginning of this video, where a patient has alcohol use disorder. They are unable to find a typical alcohol substance to ingest, and thus they are looking for substitutes or something else that has an alcohol-like substance, and they can ingest ethylene glycol, presenting with the classic findings of fruity breath, altered mental status, and potentially calcium oxalate stones. So these are the two kind of main presentations that I see them ask about, but recognize there's a lot of different things that can cause this. They can also ask about a patient with Crohn's disease, somebody ingesting too much vitamin C, and really the goal I want you to take from this video is that you recognize that anything that increases our stone forming substances, that is our calcium, oxalate, and phosphate, can lead to supersaturation, whatever that cause may be. We talked about some of the really high yield ones right here and explained why the precipitation of these conditions can vary based on their pH or the actual cause of the stones. For diagnostics, we're going to be looking at some classic and easy imaging studies that can be obtained, including an X-ray or CT. It's important to have a general idea of what the urine crystals will look like, but again, they would rarely give this to you in isolation. I just want you to associate some of these shapes or words with the different types of stones here, whether that be a calcium oxalate stone or a calcium phosphate stone. And finally, for management, the goal is really about decreasing the amount of stone forming substances in the urinary system. So that can include things like thiazides or a low sodium diet, or potentially even giving something like potassium citrate to alkalinize the urine for potassium oxalate stones, because we know the preferred environment for those forming is an acidic environment, and thus we would try to do the opposite. And finally, also very, very high yield and important, do not restrict calcium. We talked about that. The reason for this is that we're just trading one problem for another, and thus this would not be the best answer to help the patient with their condition.